Next is menstrual dysfunction. So by definition, it's abnormal pain or bleeding related to menstruation. So lots of individuals will have this. You can have primary dysmenorrhea. That's a type of menstrual dysfunction, a subclass of it. Usually you'll see this happen starts within the first 3 to 4 menstrual cycles. So you've got a young girl, she's starting her menstrual cycles, and those first few, she's going to have issues with primary dysmenorrhea, perhaps. A lot of that comes from prostaglandin release, which creates a significant amount of pain. So backaches, abdominal cramps, sometimes it will be down into the thighs, the perineal pain. About 50 to 90% of females ages 15 to 25 are going to experience primary dysmenorrhea at some point in their life. So that's potentially the majority of females. Pelvic pain, backache, headache, diarrhea, nausea, vomiting, anorexia, all of those kind of go along with primary dysmenorrhea. So if you think about how hard it is to be a teenager anyway, and then you pile this on, that can be pretty significant. Lots of school time lost related to this, and some individuals will think, oh, that's not a big deal, you know, she's just having her period. It can be significant for patients that experience this particularly frequently. So secondary dysmenorrhea is a little different. So typically it's going to follow in the back half of life, usually ages 30 to 50, and it's related to a uterine or pelvic pathology. So there's an issue there that's causing this. Some of the more common ones are endometriosis, so that uterine linings actually growing outside of the uterus. Things like ovarian cysts or uterine cysts, uterine tumors, pelvic inflammatory disease, fibroids. And we see that with secondary dysmenorrhea, it progressively worsens. So the patient typically will deal with it for a while and then will seek treatment. So a lot of times by the time they have sought treatment, it's been going on for a while. And a lot of times this is cured by sometimes hormones, medications, sometimes it's a surgical treatment. The next type of menstrual dysfunction we'll look at is abnormal uterine bleeding. So it's kind of a broad definition. So there's either too much, it's happening too often, too little, not frequently enough. Something is off about that normal pattern for that patient's menstrual cycle. A lot of times we see this in perimenopause. So patients may actually present or mention to you if they're hospitalized, hey, I'm having really irregular cycles, or I'm bleeding really heavily, or it's happening more frequently. A lot of times this happens related to perimenopause, and a lot of times it's related to those altered hormones. It can happen outside of perimenopause, but that's when you're going to see it most frequently. So sexually transmitted infections, they used to be called STDs. Now they are considered STIs, even though you'll hear STDs used as well. They can be caused by bacteria, they can be caused by viruses, fungi, protozoa, parasites, so there's a wide range of different types of sexually transmitted infections. Every sexually active individual is at risk, despite the fact that they may say, I'm monogamous and I've been in the same relationship for 40 years. But we never really know what's happening with the other partner. So every patient, if they come in with signs and symptoms of a potential sexually transmitted infection, that needs to be investigated. Newborns are also at risk of picking that up through the mom, through the birth canal. Unfortunately, a lot of times sexually transmitted infections occur in groups. They love a friend. So a lot of times if a patient has gonorrhea, they may have chlamydia as well. Or if they have a protozoal infection, then they may have gonorrhea or herpes simplex virus in addition to it. So a lot of times they figure they're going to be treated for one, then they may need to be treated for more than one. So good news is most sexually transmitted infections can be prevented with the use of a latex condom. Not all. So if there is a lesion there, let's say you have a syphilis lesion that's not on an area that's covered by that barrier, then that patient, the partner, can be exposed. Same thing with a herpes simplex virus lesion. So if it's not covered, then it can potentially be exposed. It can be tricky because sometimes patients, particularly with viral issues, have that viral shedding that we've heard about so frequently with the coronavirus. You can have viral shedding with a sexually transmitted infection as well and not even know yet that you're infected. So most can be prevented with a latex condom, but not all. It's not foolproof. Any type of hetero or homosexual penetrating and non-penetrating activity can create sexually transmitted infection. So just because they haven't had sexual intercourse doesn't necessarily mean that they cannot get a sexually transmitted infection. And particularly with younger individuals, but older individuals sometimes too, don't realize that. So that's a key teaching point as well. And then it's important too, if you have a patient that comes in with a sexually transmitted infection, that you need to find out who their partners were and identify who they were, let them know, and then we need to screen them for infection as well, and then treat that partner as well. So you've probably seen the diagrams before about this one. This individual has sexual intercourse, and then this one has sexual intercourse with this one, and then the whole breakdown of multiple individuals that can be influenced or impacted by that. So that's why we need to treat and screen everybody that has been in potential contact with those different individuals. Otherwise, it's just going to continue to relapse and spread, much like the coronavirus has. So that concludes our sexuality content for this time, at least.